Welcome to AETCM, the Emergency Medicine channel. I, Dr. SHREYA Roy, as a part of EM Rapid, would like to discuss pyelonephritis as a topic today. Definition: pyelonephritis is an infection of the upper urinary tract. Acute pyelonephritis is infection of the renal parenchymal and pelvic ileal system. Infections of the upper urinary tract can progress into three patterns of renal infection not commonly considered part of the UTI spectrum, that is acute bacterial nephritis, renal abscess and emphysematous pyelonephritis. These diagnoses are basically made based on imaging studies. Clinical features: the most striking clinical features include flank pain, costovertebral angle tenderness or specific renal tenderness to deep palpation associated with cystitis because of referred pain, fever with chills and nausea, vomiting. Basically, patient will be coming with fever and chills, nausea, vomiting, and there will be flank pain or there will be costovertebral angle tenderness on deep palpation. We can classify UTI as uncomplicated or complicated UTI. Uncomplicated UTI is UTI in a patient without any structural or functional abnormalities within the urinary tract or kidney parenchyma, without relevant comorbidities that place the patient at risk for more serious outcomes and are not associated with genitourinary tract instrumentation. Complicated UTI, on the other hand, includes infections involving a functional or anatomically abnormal urinary tract or infection in the presence of comorbidities that place the patient at risk for more serious adverse outcomes. Classification: acute simple cystitis and acute complicated UTI. So, in acute simple cystitis, that is uncomplicated UTI, it is generally confined to the bladder and typical symptoms include dysuria, urinary frequency, urinary urgency and suprapubic pain. Acute complicated UTI is accompanied by features that suggest extension beyond the bladder, that is fever which is more than 99.9 degree Fahrenheit, chills, rigors, significant fatigue or malaise beyond baseline or other features of systemic illness. Patient can be having flank pain, costovertebral angle tenderness, pelvic or perineal pain in males, and symptoms of cystitis may or may not be present. Because in case of any diabetic patient, fever might not be overt. Then coming to diagnosis, a definitive diagnosis of UTI combines appropriate historical findings with laboratory confirmation. However, a clinical diagnosis of UTI is made in the emergency department based on history, physical examination and supportive laboratory findings rather than confirmatory culture. So, urine analysis: the clean catch midstream voiding specimen is as accurate as urine obtained by catheterization if the instructions are followed properly. So, basically in a normal urinary, the RBCs of a female should be 0 to 5, RBCs of a male should be 0 to 3, WBCs should be 0 to 4 and bacteria should be none per high power field, and that too in a centrifuged specimen. And if you are going to look at the leukocyte esterase or the nitrate, it should be none in the dipstick test and the sample should be a fresh urine. So, urine WBC count or pyuria by microscopy. The assessment of pyuria using standard centrifuged urine is imperfect due to variable specimen preparation techniques. A WBC of count more than 5 cells per high power field in a centrifuged specimen from a symptomatic patient is abnormal. Although the combination of pyuria and bacteriuria is likely to be found with typical coliform infections, lower degrees of pyuria with or without bacteriuria may be clinically significant, especially in the presence of UTI symptoms. In a symptomatic patient who has less than 5 WBCs per high power field in a centrifuged specimen, other causes of false negative pyuria should be considered, such as dilute pre-centrifuged urine, systemic leukopenia or patient self-treatment with leftover antibiotics. Pyuria may be intermittent or absent if the patient has an obstructed or infected kidney. In men, more than 1 or 2 WBCs per high power field in a centrifuge specimen can be significant when bacteria are present. Urethritis and prostatitis are far more likely causes of pyuria in young males who are sexually active and complain of dysuria, regardless of the presence or absence of urethral discharge. So, bacteriuria by microscopy is a sensitive tool for detection of UTI in a symptomatic patient. The presence of any bacteria on a gram-stained specimen of uncentrifuged urine is significant and highly correlates with culture results of more than 10 to the power 5 colony forming units per ml. For gram-stained centrifuge specimens, more than 1 bacterium per high power field is 95% sensitive and more than 60% specific to predict a culture with 10 to the power 4 colony forming units per ml. Both of these methods for looking of bacteria under the microscope fail to detect low colony count UTI or infections caused by chlamydia. False positive results can occur when vaginal or fecal contamination is present. Female patient with symptoms suggestive of UTI and vaginal discharge or dyspareunia should have a pelvic examination to investigate for pelvic inflammatory diseases. Urine and blood culture. For patients with typical symptoms of cystitis or an uncomplicated UTI and positive findings on urine analysis, pyuria on microscopic examination, bacteriuria in a gram-stained specimen, positive leukocyte esterase test result and or positive urine nitrate test results, urine culture is usually not indicated. Urine culture should be performed for the following patients: those who have complicated UTI, pyelonephritis, sepsis, recent antimicrobial treatment. And the primary indication of blood culture in patients with suspected UTI is clinical sepsis. Coming to microbiology, E. coli is the most frequent cause of acute complicated urinary tract infection. Other uropathogens include other Enterobacteriaceae, could be Klebsiella species, Proteus species, Pseudomonas, Enterococci and Staphylococcal, both methicillin sensitive as well as methicillin resistant. So, in uncomplicated UTI, the organisms mostly are E. coli, Staphylococcus saprophyticus, Klebsiella pneumoniae, Enterococcus faecalis. In complicated UTI, it is E. coli, Enterococcus species, Klebsiella pneumoniae, Candida species, Staphylococcus aureus, Proteus mirabilis and Pseudomonas aeruginosa. In other catheter associated UTI, it could be E. coli, Enterococcus coagulatus negative Staphylococcus, Candida, Pseudomonas aeruginosa, Proteus mirabilis or Morganella morganii. Recurrent UTI, it will be same as above depending on the patient's risk factors. Now coming to imaging. Renal imaging in adults are not indicated in otherwise healthy patients with uncomplicated UTIs who can be managed as outpatients. Imaging is reserved for patients suspected of alternative diagnosis that may explain the symptoms or after failure of conventional treatments. Other indications would include males, elderly people, diabetic people, severely ill patients and acute worsening of renal function, that is GFR less than 40 ml per minute. Now imaging. Most patients with acute complicated UTI do not warrant imaging studies for diagnosis or management. Imaging is generally reserved for those who are severely ill, have persistent clinical symptoms despite 48 to 72 hours of appropriate antimicrobial therapy or have suspected urinary tract obstructions. Example, if the renal function has declined below baseline or if there is a precipitous decline in the urinary output. Imaging is also appropriate in patients who have recurrent symptoms within few weeks of treatment. The main objective of imaging is to evaluate for a process that may delay response to therapy or warrant intervention such as calculus obstructions or to diagnose complications of infection such as renal or perinephric abscess. Imaging should be obtained urgently in patients with sepsis or septic shock to identify any evidence of obstruction or abscess that required urgent source control. CT scan of the abdomen and pelvis with or without contrast is generally the study of choice to detect anatomic or physiologic factors associated with acute complicated UTI. CT without contrast has become the standard radiographic study for demonstrating calculi, gas forming infections, hemorrhage, obstructions and abscesses. Contrast is needed to demonstrate alterations in the renal perfusion. CT findings of pyelonephritis include localized hypodense lesions due to ischemia caused by marked neutrophilic infiltrations and edema. Complications. Acute complicated UTI could also present with bacteremia, sepsis, multi-organ dysfunction syndrome, sepsis and or acute renal failure, usually more likely to occur in patients with urinary tract obstruction, recent urinary tract instrumentation, patients who are older and have diabetes mellitus. Acute pyelonephritis can be complicated by progression of the upper urinary tract infection to renal corticomedullary abscess, perinephric abscess, emphysematous pyelonephritis, papillary necrosis, xanthogranulomatous pyelonephritis. Risk factors for such complications include urinary tract obstruction and diabetes mellitus. Coming to xanthogranulomatous pyelonephritis. Xanthogranulomatous pyelonephritis is an unusual variant of chronic pyelonephritis in which there is massive destruction of the kidney by granulomatous tissue containing the lipid-laden macrophages. It is thought to be due to aberrant inflammation as a result of macrophage defect in microbial processing. Clinical presentation in adults, xanthogranulomatous pyelonephritis most commonly occurs in middle-aged females with a history of recurrent UTI, particularly with E. coli, Proteus mirabilis and Pseudomonas aeruginosa, Enterococcus faecalis and Klebsiella species. In children, xanthogranulomatous pyelonephritis can involve the entire kidney or may be localized, mimicking a tumor, and is most commonly associated with Proteus and E. coli. Xanthogranulomatous pyelonephritis is a rare complication of kidney transplantation. Presenting symptoms include flank pain, abdominal pain, fever, malaise, weight loss or growth retardation. A unilateral kidney mass can usually be palpated with blood tests which can reveal evidence of non-specific systemic inflammation. In some cases, chronic inflammation can lead to secondary amyloidosis to the nephrotic syndrome So, evaluation and diagnosis. A high level of suspicion is required for the diagnosis of renal or perinephric abscess and should be Now, coming to renal and perinephric abscesses. Renal and perinephric abscesses can occur as complications of pyelonephritis, usually due to gram-negative enteric bacilli, or in the setting of bacteremia with hematogenous seeding, usually due to Staphylococcus aureus. Both processes start with the tissue necrosis. Renal abscess is a walled-off cavity, whereas perinephric abscess consists of a more diffuse liquefaction foci located between the renal capsule and the Gerota's fascia. Clinical manifestations would be do not evoke as a specific diagnosis. Patients will be having fever, flank pain, laboratory evidence of chronic inflammation. Although dysuria, pyuria and proteinuria may be present, urinary symptoms and urine analysis abnormalities are not uniformly reported. The presentation may be especially subtle and insidious in older adults and in individuals with autonomic neuropathy, usually in the setting of diabetes or chronic alcoholism. Imaging findings. Abnormalities associated with renal and perinephric abscesses can be visualized on various imaging modalities, including plain radiographs, ultrasound and computed tomography. On CT, renal abscesses appear as intrarenal walled-off cavities. Perinephric abscesses are usually confined to the perinephric space by Gerota's fascia, but may extend to the retroperitoneal structures and rupture into the collecting system. Evaluation and diagnosis. A high level of suspicion is required for the diagnosis of renal or perinephric abscesses, which should be considered in a patient presenting with symptoms and signs of, or in a patient with pyelonephritis who are slow to respond to therapy. Identification of a renal or perinephric abscess on ultrasound or computed tomography confirms the diagnosis. CT with contrast enhancement is the best imaging procedure for identification of renal or perinephric abscess. Blood and urine culture should be collected at presentation in order to identify a causative pathogen. In some cases, particularly with perinephric abscesses, a sample of the abscess may be required for microbiological diagnosis, in which case drainage is indicated. Antibiotic therapy. For empirical therapy, we suggest a parenteral regimen that can provide broad spectrum coverage against methicillin resistant Staphylococcus aureus and gram-negative bacilli. Examples include vancomycin plus one of the following, that is piperacillin, tazobactam, cefepime, meropenem or imipenem. Once the culture and susceptibility results are out, the regimen can be tailored according to a narrower agent and following abscess drainage if indicated and clinical improvement. Percutaneous drainage. Indications for renal abscess drainage for or therapeutic purpose depend on the size of the abscess, whereas drainage is often indicated for perinephric abscesses. For diagnostic purpose, percutaneous drainage is generally preferred because it is decreased morbidity compared with surgical drainage. For renal abscesses more than or equal to 5 mm in diameter, we suggest immediate percutaneous drainage. For perinephric abscesses more than or equal to 3 cm in diameter, which suggests immediate percutaneous drainage. Smaller abscesses may also warrant percutaneous drainage for microbial diagnostic purposes. Otherwise, for smaller abscesses, we defer drainage and manage with antibiotic alone. If clinical symptoms and radiographic findings persist despite several days of appropriate antibiotic therapy, we proceed with percutaneous drainage. Surgical interventions for selected cases can be required. Now, emphysematous pyelonephritis. Definitions: emphysematous urinary tract infections are infections of the bladder, renal pelvis that is pyelitis, or kidney, it is pyelonephritis, that are characterized by gas formation. Microbiologically, E. coli and Klebsiella pneumoniae account for most cases. Risk factor wise, the major risk factors are diabetes mellitus, urinary tract obstruction. These infections primarily occur in females at a mean age of about 60 years. Emphysematous pyelitis or pyelonephritis. Clinical presentation and diagnosis. Clinical features are indistinguishable from those seen in severe acute pyelonephritis, that is fever, flying pain or abdominal pain, nausea. The diagnosis is made in a patient with UTI, symptomatic pyuria and bacteriuria who has air in the collecting system, renal parenchyma or the perirenal tissues on CT scan. Management of isolated pyelitis. For patients with gas limiting to the collecting system, antimicrobial therapy with relief of any urinary tract obstruction is generally sufficient to treat the infection. Management of renal or perirenal involvement. We suggest percutaneous drainage of gas and purulent material rather than no intervention, in addition to antimicrobial therapy and relief of the obstruction. Now, the diagnosis of acute complicated UTI is made in the following clinical scenarios: symptoms of cystitis, that is dysuria, urinary urgency and or urinary frequency, along with fever more than 99.9 degree Fahrenheit, or other signs and symptoms of systemic illness such as chills, rigors or acute mental state changes. In such cases, pyuria and bacteriuria support the diagnosis. Flank pain or costovertebral angle tenderness in the setting of pyuria and bacteriuria, this is suggestive of pyelonephritis. Fever and typical symptoms of cystitis are usually present, but their absence does not rule out the diagnosis. CT findings that support the diagnosis include attenuation, low attenuation extending to the renal capsule on contrast enhancement with or without swelling, and complications such as renal abscesses. However, the normal CT does not rule out the possibility of mild pyelonephritis. Fever or sepsis without localizing symptoms in the settings of pyuria and bacteriuria may be attributed to UTI if other causes have been ruled out. Careful clinical assessment is necessary. The diagnosis of acute complicated UTI is unlikely if pyuria is absent. The presence of bacteriuria, that is more than 10 to the power 5 colony forming units per ml of a uropathogen with or without pyuria in the absence of any symptoms that could be attributed to a UTI is called asymptomatic bacteriuria and generally does not warrant treatment in non-pregnant patients who are not undergoing any urological surgery. Now, this is a chart showing empirical treatment of inpatient management of pyelonephritis. It's taken from Tintinelli and complicated urinary tract infection. So, the antibiotics mentioned are ciprofloxacin, ceftriaxone, cefotaxime, gentamicin or tobramycin, piperacillin, tazobactam, cefepime, ertapenem, imipenem, meropenem, and the dosage is everywhere mentioned, that is ciproflox 400 milligrams IV every 12 hourly, ceftriaxone 1 to 2 grams IV once daily, cefotaxime 1 to 2 grams IV every 8th hourly, piptaz 3.375 grams every 6th hourly, meropenem 1 gram every 8th hourly, and imipenem 500 milligram every 8th hourly. So, in inpatient treatment, the diagnosis of acute complicated UTI can be made in the following clinical scenario. We have cystitis symptoms and pyuria with either the temperature is more than 99.9 degree Fahrenheit or there are signs and symptoms of systemic illness. Example, chills, rigors, acute onset of fatigue or malaise. Then patient is complaining of flank pain or costovertebral angle tenderness with pyuria, fever or sepsis in the setting of pyuria without evident cause of infection. So, we need to, in such a scenario, we go ahead and take the urine culture and susceptibility testing, and we look for these questions. Are any of the following present? That is critical illness warranting intensive care, that is severe sepsis, or any suspected or documented urinary tract obstruction. If any of these features are there, we come to yes, then we obtain an abdominal or pelvic imaging, and also obtain urologic consultation to evaluate and manage potential urinary tract obstruction if relevant. Then, is the community institutional rate of ESBL producing organisms known to be low? If the answer to that is no, then we can go ahead with broad spectrum gram negative and gram positive coverage antibiotics, which include ESBL. So, either we go ahead with meropenem or imipenem plus added coverage of vancomycin or any other broad spectrum gram positive organism. So, meropenem or imipenem with vancomycin is if it is an institution or community which produces high rate of ESBL. Now, in the same scenario, if the community or institution rate of ESBL producing organism is low, then we shift here. Then, are there any risk for an MDR infection? What are the risks? These are the risks. In the prior 3 months, any MDR urinary isolate, previous history of any MDR urinary tract isolate is there, or any fluoroquinolone resistant Pseudomonas urinary isolate. Inpatient stay at the healthcare facility, example hospital, nursing home or long term acute care facility, then also there is chance of hospital acquired infections. Then use of a broad spectrum antimicrobial, example fluoroquinolone, trimethoprim sulfamethoxazole, third or later generation cephalosporin in the last 3 months, and travel to parts of the world with high rates of MDR organisms. If these things are present, we need to start on broad spectrum gram negative coverage, that is cefepime, piptaz, meropenem if there was an ESBL isolate, and imipenem if there was a recent ESBL isolate. But if there is no risk factor for an MDR infection and the answer to all these questions are no, then we can go ahead with the standard spectrum gram negative coverage, that is ceftriaxone or alternatively ciprofloxacin or levofloxacin. The doses are mentioned in the box here, you can go through that. Now, in outpatient settings treatment. So, the diagnosis of acute complicated UTI here can be made in the following clinical scenario. So, there is cystitis symptoms with pyuria and pyuria with either temperature more than 99.9 degree Fahrenheit and signs and symptoms of systemic illnesses. Then flank pain or costovertebral angle tenderness with pyuria, fever or sepsis in the setting of pyuria with or without other evident cause of infection. Then we come to urine culture and susceptibility testing. Are there any risk factors for an MDR infection? These are the same questions, that in the last 3 months whether there was any MDR urinary isolate or any isolate which is resistant to fluoroquinolone, inpatient stay at a healthcare facility, any broad spectrum antibiotic usage, that is fluoroquinolone, trimethoprim sulfamethoxazole or third generation cephalosporin, or travel to parts of the world with high rates of MDR organisms. If such history is there, then we come to these questions. Does the patient have any contraindication to any fluoroquinolone like allergy or intolerance or some drug reactions which might occur? And then high risk for fluoroquinolone resistance, specifically previous history of fluoroquinolone resistance isolate within the last 3 months and history of fluoroquinolone use in the last 3 months. If it is there, then we start with ertapenem once daily until culture and susceptibility test results are there. And patients at risk for fluoroquinolone resistant Pseudomonas, example because of a prior recent isolate, were in different management. Okay. Then coming, if there is none of these are present, then we come to ertapenem once, followed by a fluoroquinolone which is ciprofloxacin or levofloxacin. Then if there is no history of any MDR infection, there is no susceptibility or there is no risk of any MDR infection, then we have to look for any contraindications to any fluoroquinolones, that is allergy or any drug reaction. If there is, we can go ahead with ceftriaxone, ertapenem, gentamicin, tobramycin, followed by a non-fluoroquinolone agent, that is amoxicillin clavulinate, cefpodoxim, cefadoxil, trimethoprim sulfamethoxazole. And if there is no contraindication to fluoroquinolones, then we might start we have to ask the question, is the community prevalence of fluoroquinolone resistance known to be more than 10% for E. coli? If it is yes, one dose of ceftriaxone, ertapenem, gentamicin, tobramycin, followed by ciprofloxacin or levofloxacin. And if it is no, then directly we can start with ciprofloxacin or levofloxacin. This is a chart again with the same hospitalized, outpatient, which antibiotics to start. This is another one, guidelines for outpatient management of UTI including pyelonephritis for adult female or male, adult female uncomplicated cystitis and adult female for lower urethritis, and adult female or male for complicated UTI as well as pyelonephritis is going to be this one, where we use ciprofloxacin, levofloxacin. Only if susceptibles are known, then we can consider trimethoprim sulfamethoxazole, amoxicillin, clavulanic acid, cefpodoxil, the same thing that we have already talked about. So, I hope this was useful to you, and thank you.